You know how I know it's officially spring in Minnesota? It's trauma season. For those of us in EMS, the Start Seeing Motorcycles bumper sticker becomes very graphic this time of year. I know because I was involved with 2 critical resuscitations this past weekend related to motorcycle accidents. Which brings us to the LifeLink 3 base in Anoka, where crews stand ready 24 hours a day to respond to the worst accidents throughout Minnesota and western Wisconsin. As the TV commercial goes, they know a thing or two because they've seen a thing or two. This month, let's review a few topics to get you ready for trauma season. I'll keep you up to date on the latest local EMS news. Dr. Robinson will review our Cric procedure, and we'll talk about the effects fatigue has on our bodies. So here we are, it's May. I'm Dr. Peterson, this is Regions EMS Update, and those are the 3 things you need to know. How many times have you heard a partner complain about being tired, or worse, could see that they were too tired while working? For the first time in EMS, this issue has finally been brought up by the National Association of State EMS Officials in their 2018 Fatigue Risk Management Guidelines for Emergency Medical Services. In this document, they define fatigue, the effects on EMS workers, and introduce guidelines to address keeping our workforce sharp. So what is fatigue? Fatigue refers to a subjective, unpleasant symptom which incorporates total body feelings ranging from tiredness to exhaustion, creating an unrelenting overall condition which interferes with an individual's ability to function to their normal capacity. Whew, but don't take my word for it. Check this out. Here's what you need to know.
Fatigue, it is something we have all experienced at some point. Maybe you felt tired, had difficulty staying focused, lacked motivation, or maybe your eyes felt like lead and you found it hard to stay awake. But what is fatigue actually? There are many definitions, but if we really want to understand fatigue, we must differentiate between 2 existing types: physical fatigue and mental fatigue. With physical fatigue, your muscles feel worn down and hard to operate, while mental fatigue affects your cognitive functions. There are 2 types of fatigue. The 2 types of fatigue have different causes and must be treated accordingly. Let's take physical fatigue. The main trigger that causes it is physical exertion. Imagine running a marathon and pushing your body to its limits. Naturally, it reacts and gives you a signal to stop and recharge. Physical fatigue can also be made worse by illness, lack of appropriate nutrition, and dehydration. However, physical exertion is the main cause. To cure fatigue caused by physical exertion, you need to rest, just like an athlete. In order to keep performing at an optimal level in sports like basketball, players take frequent turns on the bench to recover before returning to the court again. So, to counter the effects of physical fatigue, ensure you take rest breaks at regular intervals. Mental fatigue, however, is triggered mainly by lack of sleep. Illness and stress may also contribute, but lack of sleep is the main cause. To cure mental fatigue, resting is not enough. What you need is a sufficient amount of good quality sleep to replenish yourself. In regards to your safety and well-being, mental fatigue typically represents a larger risk than physical fatigue. If you become physically fatigued, but continue to exert yourself, you stand the risk of picking up a soft tissue injury, such as a sprain or strain. But if you become mentally fatigued, things become more dangerous, as critical activities such as driving whilst drowsy can lead to disastrous consequences. Regular mental fatigue can also decrease your well-being by reducing your energy and motivation to engage in health-promoting activities such as exercise and spending time with family and friends. To effectively manage fatigue in any organisation, therefore, it is important to prioritise addressing mental fatigue caused by lack of sleep. From a company perspective, this starts with appropriate roster design and ensuring employees have adequate breaks and free time to get the sleep they need. It may also entail providing employees with training on how to optimise the quantity and quality of sleep they obtain. From a personal perspective, it is important to use your breaks and free time appropriately by getting enough sleep and addressing sleeping problems quickly when they occur. In the event you find yourself too tired to work safely, you should immediately communicate this to your supervisor or other appropriate person. In all cases, your safety and well-being is what matters most, and this starts with making sleep a priority.
Work-related fatigue affects more than half of emergency medical services personnel. In addition, the same amount report poor sleep quality and inadequate recovery between scheduled shifts. The National Sleep Foundation recommends that adults obtain between 7 and 9 hours of sleep per day. Most adults in the United States only get 7 hours of sleep, but on any given day, 1/3 report inadequate sleep in the previous 24 hours. Most EMS clinicians don't meet the National Sleep Foundation recommendations for sleep. In fact, you're probably laughing at me right now thinking about the concept of 8 hours of sleep per night. Half of EMS personnel sleep only 6 hours per day, and over 70% report some form of insomnia. Lack of sleep and its effect in the form of fatigue is a threat to the safety of you as EMS personnel, your patients, and the public. The odds of injury, medical error, adverse events, vehicle accidents, and safety-compromising behaviors are higher among fatigued EMS personnel than non-fatigued personnel. Ambulance crashes, line-of-duty deaths, and patient mortality have been linked to sleep and fatigue in EMS personnel. Despite the dangers of fatigue, guidance for mitigating fatigue in the EMS workplace has been limited. If you'd rather not read the entire report, here are the 5 recommendations from the 2018 Evidence-Based Guidelines for Fatigue Risk Management in EMS. Use fatigue or sleepiness survey instruments to measure and monitor fatigue in EMS personnel. Personally, I'm not sure that many of us would remember to take the time to fill out a survey on shift, but I guess there's really no other way to measure this in real time. EMS personnel should work shifts shorter than 24 hours in duration. This might be heresy, as I know most of you work 24-hour shifts on a regular basis. I'm just a messenger here, but I do have concerns about anyone's critical thinking skills after 24 hours on duty, regardless of how much sleep you think you got. EMS personnel should have access to caffeine as a fatigue countermeasure. Yes, it's true, there is evidence that caffeine makes you smarter when you're tired. It's not the best solution to the problem, but it's better than just powering through. EMS personnel should have the opportunity to nap while on duty to mitigate fatigue. Makes sense, but I know a few city council members who don't like to pay people to sleep. I'm on your side here. Public safety is a 24-hour-a-day profession, and even robots have to plug in to recharge once in a while. EMS personnel should receive education and training to mitigate fatigue and fatigue-related risks. This one's on us. You're welcome.
Hi, I'm Dr. Liz Robinson, and today we'll be discussing cricothyrotomies. First, let's discuss the indications. This would be a good procedure to do on somebody who you cannot intubate and you cannot ventilate. Some examples of this would be someone with massive orofacial trauma, someone with a proximal airway obstruction, such as choking, or someone that has significant swelling of their upper airway from anaphylaxis, chemical or heat burns, or epiglottitis. Contraindications to this procedure would be a patient under the age of 8 years old or someone that has such distorted landmarks that you have no ability to start the procedure. So let's get down to the cricothyrotomy. First, let's discuss positioning of the patient during this procedure. Essentially, you want their head in a neutral position where it's not going to be moving around for the procedure. The reason this is important is the trachea is going to move up and down as you tilt the head up and down. To palpate your landmarks, you're going to start at the suprasternal notch, which is the top of the rib cage. You're going to palpate up, feeling the trachea. As you feel your first bump and then a divot is going to be your cricothyroid membrane. As you push up further, you're going to feel the big bump up, which is your Adam's apple. You need to stay below the Adam's apple. The reason we don't palpate from above is you're very likely to mistake the hyoid bone or the top of the thyroid as the cricothyroid membrane. This can cause damage to the larynx and the vocal cords, which may need to be surgically repaired. It's still better to choose this landmark accidentally than not do the procedure at all. So attempt to find your landmarks quickly and continue doing the procedure. Once I have my landmark, I'm going to use my top hand to stabilize the tissue and provide traction. I'm going to use my 10 blade, which is the scalpel with a rounded edge, and I'm going to keep it parallel to the patient because the sharp end of the scalpel is actually the bottom part, not the top part. In one smooth maneuver, I'm going to cut down while providing traction. In this model, you'll see a fair amount of muscle tissue. You likely won't in an adult's patient. So I'm cutting down, and now I have the tissue exposed. At this point, it's going to be extremely bloody, and I'm not going to be able to see my landmarks. So again, I'm going to palpate in the area, and I found my cricothyroid membrane, and I'm going to take my sklar hook and poke it into this. Once I feel a give, and I have traction when I pull up, I know that I'm in the right space. If you have an assistant, you can have your assistant hold the sklar hook while you continue the procedure. Now that the sklar hook is in the trachea, I'm going to take my scalpel and ride it down my sklar hook to make sure that I stay in the same hole I'm in, stab down into the membrane, twist, and lift up. I can put down my scalpel, and now I'm going to advance my bougie through the hole that I just made. I'm going to advance it until I feel a hard stop at the carina. I'm going to take out my sklar hook and load my ET tube onto this. So my ET tube may have a little bit of trouble going through the hole, so I'm going to twist as I advance. Once I see my balloon go through the hole, I'm going to stop, as that is a correct depth to put your ET tube. I'm going to pull out my bougie, inflate my balloon, and now you can start bagging the patient. When I'm holding, while we have the airway unsecured, I'm going to put my hand on the patient to make sure if I hit a bump, this tube doesn't get dislodged, and then put my hand over the tube. This is the securest way to hold it while you're waiting for the tube to be secured. The best way to secure a tube is going to use some sort of fabric tape, which should be included in your kit. You do not want to use adhesive tape for this step because remember, this is going to be a bloody mess and you're going to have nowhere to tape it down to. You're going to put the tape under the patient's neck, and then you're going to tie it around the tube. The specific way to tie it doesn't quite matter, as long as the tie that you put in place, you can untie very quickly, so this shouldn't be a knot. After this step, continue bagging the patient and transport them quickly to the emergency department. After you insert your ET tube, you're going to verify placement the same way you would with any other intubation. And what that means is, I want to see an end tidal and look at waveform, and you're going to listen for lung sounds over the gastric area and watching for chest rise. So let's review. A cricothyrotomy is a procedure that should only be performed if a patient cannot be intubated and cannot be ventilated by any other means. For the paramedic, the most important thing is to create a vertical midline incision that's long enough for you to be able to expose your landmarks even if the patient shifts a little bit up or down. For the EMT, it is very helpful if you can cut the ET tube down prior to insertion so that less of it is hanging out during the procedure. These procedures do happen in the wild, and if you're the one who successfully performs it, you're the hero.
Hi, I'm Dr. Peterson, and this is a Regions EMS update. Last month, we presented the Inception research study proposed by Dr. McGonigal, Trauma Medical Director with Regions Hospital. As of May 16th, this study is active. Although only a few agencies are officially participating in the study, MRCC will be asking every provider the same question when you call in a trauma team activation. Which number or criteria are you using to activate the TTA? This information will ultimately be used to determine the accuracy of each criterion in predicting the need for time-sensitive interventions. If you're not sure, that's okay. A research intern will assist you in the ED if your agency is participating in the study. Questions? Contact Dr. McGonigal or myself directly. If you are part of Regions EMS CME this quarter, you might be introduced to a new triage algorithm called RAMP. We have spent countless hours and all-nighters discussing this. Well, not really, but it feels like it. It comes down to the fact that a true MCI, where you truly do not have enough resources to save everyone, rarely happens. The reality is that for almost every incident we encounter, we will be able to treat and transport everyone who needs it. But if you ever find yourself in a situation where you have no choice but to decide who lives and who dies, the current thinking is that the decision needs to be simple and intuitive. RAMP fits the bill. There are only two questions. Are they alert, and do they have a pulse? We know that hypotension and head injuries are a bad sign, as each 10-point drop in blood pressure below 120 increases the mortality by almost 20%. You're much better off spending your limited resources on patients with a better chance of survival. When it comes to regular multi-victim day-to-day triage, SALT and START are fine, but honestly, your intuition probably does a pretty good job too. We will be adding RAMP to our guidelines, but encourage you to continue to use critical thinking skills and an organized process during MCI situations. Let's talk about performance metrics. Last month, we convened a group of frontline providers from each agency to start to dig into some of our performance metrics to try and improve patient care. A lot of ideas came out of this, but to start with, we would like to focus on aspirin documentation for chest pain. Anyone over the age of 30 who is complaining of any cardiac symptoms must have aspirin documented. It's fine to put it in the narrative, but to prevent one of us from having to read every single patient care report, we also need it documented in the medication section. This is very important as we work to prove the value and quality of the care that we provide to patients before they get to a hospital. If they already took aspirin or refuse for some reason, you can still record it and use the checkboxes or comments field to indicate this. We would like to reach 100% of our goal within 100 days. So let's see what improvement I can report on over the next few months. Medication shortages. This month we have a doozy. Amiodarone vials are coming out of stock currently. The only alternative is 100 cc bags with 100 milligrams in the bag, which means that you'd have to push 300 cc's through an IO in a cardiac arrest situation to give the first dose. Not too practical. So for now, if you do not have amiodarone, the medical directors have authorized lidocaine as a substitute for amiodarone. The dose is a standard 100 milligrams for adults and 1 milligram per kilogram for pediatric patients. This can be repeated once after 10 minutes at the same dose. But for those of you who have ever given lidocaine, we will not be starting a drip prior to hospital arrival. So to recap, lidocaine can be given for VFib or VTAC in place of amiodarone at a dose of 100 milligrams for adults, 1 milligram per kilogram for kids, and can be repeated one time after 10 minutes. You will see a guideline update pushed out to our website and mobile app to account for this. And finally, happy EMS week to all of you pre-hospital providers out there. Unfortunately, with the construction around Regions Hospital, we lost our space for our annual rig wash, but we are still thinking of you and we greatly appreciate everything you do each day that you show up for work. That will do it for our studio update this month. Thanks for watching, and we'll see you next month. To wrap this up, I was hoping to be able to rappel from a helicopter with a bunch of fuel tanks exploding in the background. I thought that would have been pretty awesome, but the pilot and our Health Partners insurance carrier didn't quite agree with me. That's okay, I guess. We'll just do our boring old ending sequence again. Hopefully you learned something this month, but if not, please let us know. There are several easy ways to communicate with our education team, although most of them involve social media. We'd love to hear some feedback. Thanks for watching, and for all of us at Regions EMS, I'm Dr. Peterson. Stay smart, stay safe, and stay professional.